Hello and good afternoon, everyone. Welcome to today's webinar. My name's Lauren. I work for the Coventry Health Determinants Research Collaboration. I'm based at Coventry City Council, and I'm really pleased to welcome Nikki Holliday today, who will be delivering this webinar. Nikki is a design manager at Coventry University, which is one of our HDRC collaborating organisations. And Nikki has a wealth of experience doing research with user-centered design, co-creation methodology, and importantly, involving the public in research, which is the topic of the webinar today. So Nikki will be presenting about public involvement, and then we'll have some time for questions at the end. So please do feel free to pop questions in the chat. We'll make a note of those as we go along and then cover them at the end. As I said, this session is also being recorded, and that recording will go on our YouTube channel. So yeah, I'll hand over to Nikki now, who's going to be leading the session today.
Okay, thank you, Lauren. Okay, just give me a moment to share my screen. Right, sorry about that. Hi, everyone. As Lauren said, my name is Nikki Holliday, and I'm a design manager at Coventry University. So today I want to talk to you about involving the public in research. That's also known as PPIE, Patient and Public Involvement and Engagement in Research. So what will we cover today? So I will talk about what public involvement in research is, why it's important, when do we do it, who do we include, how do we do it, ethical and best practice considerations, and then I'll go through a case study of a project where I have included the public in a research project I was involved in, and then hopefully we'll have some time for questions. So what is patient and public involvement in research? It's essentially research that is done with people or by the public and not to them or for them on their behalf, just presuming what we think that they want out of research and service development. So it means that patients or other people with relevant lived experience contribute to how the research is designed, conducted and disseminated and shared post-project. So it doesn't refer to the actual research participants taking part in a study, it's the activities that are sort of around and support that. So the public and patients contributing to how that research takes place, what methods are used, how they're developed, how we recruit participants, and things like that. Why is it important? First of all, it ensures that we're conducting the research that's relevant to the public. We're not just presuming, we think we know what's important and what's relevant to be looking at in society. It also ensures that the design of the research is acceptable to public, and we don't want to waste time or resources developing a research project where the methodology just isn't acceptable to the public, and therefore we don't get people taking part as research participants. It ensures that participant information and any other research documentation, information leaflets, consent forms, advertising materials, it can help to make sure that those resources are understandable to patients and public and the people we want to attract into our research. It can improve the participant experience of research. So I think it's important that when people are giving up their time to take part in research, first of all, we don't do any harm to people and it's a safe thing for them to do. But also, you know, is it enjoyable for them? Is it worthwhile for them? When people give up their time to take part in research, we should really be mindful of that and value that contribution that people are making to research. It improves the communication of the results to patients and the public post-study. So it makes it more likely that the results will have impact outside of sort of just publishing in academic journals, and the public can really understand what happened with the research and the implications for that going forward. It can improve the quality of the research. As I said before, it can make it more likely that we actually get the number of participants we need, because the methodologies are more suited to that patient group. And by that, we're going to get better quality data. Funder requirements. A lot of research funders now expect to see patient and public involvement in research. That doesn't mean that it should just be a tick box exercise to appease the funder, but funders are really recognising the importance of involving patients in our research. And for a lot of funders now, it's a requirement when you apply for money. It can also improve the skills of public and patients. So as well as just engaging with them to get feedback on how you're carrying out your research, you can actually improve their skills and upskill them and educate them about the research process. And most importantly, I think it empowers the public and patients and giving them a feeling of contributing to hopefully positive change. And that positive change is more likely if we involve patients in our research journey. So when do we do patient and public involvement? When do we bring them in? So in an ideal world, it's every single stage of the research cycle. So at the very top here, we have idea generation. So speaking to the public and patients as you're developing those initial ideas, rather than coming up with an idea and then going to the public with it. We can seek their input on the research design. So exactly how we carry out the research, what methods we're using. Seeking and applying for funding. There are patient public members who are trained in and are happy to learn about how to read grant applications and give you feedback on the grant application. We can get them involved in recruiting participants. So not necessarily doing the legwork, but speaking to us about where is the best place to go to find participants. You know, are there any particular community groups or charity groups that we should be engaging with? How should we develop our resources to recruit participants? Should it be leaflets in the library? Should it be something on social media? Are video, are informational videos preferable to reading about something? We can also involve them when we're actually conducting the research. So some of the projects I've had, we have PPIE members actually sitting in our research management boards and going with us right through the research journey. So if we have a problem in the research, we can get the public point of view on how we solve that problem and move forward. You can also get the public involved in analysing and interpreting results, just to get that another eye on your results to make sure you're interpreting people's feedback in the correct way and you're not missing anything. And then also post-project, we can get them involved in the implementation of new services and evaluating the impact of our research. So that's kind of the research cycle in a nutshell, and we can involve patients and the public at every single stage of that. So when we're talking about patients and the public, who do we need? Who do we need to include in our research? So broadly, it's people with the relevant lived experience to the project we're looking at. And this can be the patients themselves, but also think a bit more widely than this. So think about their friends, their family, their carers. There are other people who might be impacted by the research. So if the research is into a new healthcare service, it's not just the patient who might be attending that healthcare service, their carers might be taking them to that service and experiencing it in their own way. So they might have some input into how that service should be run. Thinking about equality and diversity, does your patient and public involvement group represent the wider population, or is it just going to be an echo chamber for one particular group of people? If we really want the patients and public to have a useful say in our research, then we need to make sure that our research is representing the patient group that we're seeking to help, and we don't want to be sort of excluding any voices within that. And it's not technically patient and public involvement, but you might also want to think about the inclusion of wider stakeholders when you're looking at research and service development. So that could be anyone who's involved in a care pathway, who might have some sort of input and say in how a new healthcare service or local service should be run. So although it's very important to get that patient and public feedback, there's so many other actors involved in the delivery of not just research projects, but the eventual sort of intervention or service or treatment that you might be delivering outside of that research project when everything's finished, that can contribute to the success or the failure of the ultimate intervention. So as well as patients and the public, also think about sort of all those people in the care pathway that might be involved, and that could be clinicians, it can be receptionists, administrative staff. There's a wide range of people that could sort of really have a say in how research is conducted to, develop interventions that really work in the real world. So how do we do patient and public involvement? So your methods that you want to work with will depend upon how you intend to engage with patients and the public and your level of involvement, and in particular where you sit on the ladder of participation. So this ladder here shows the different levels of engagement that we can have with people. So right at the bottom there's coercion, that's just doing things to people, presuming we know what's best for people, just implementing research, implementing services with no say from patients or the public. And then the next step up is educating them. So we're just going to do it, but we'll at least tell you about it. I'm not going to talk about those two rungs of the ladder today because it's not something that we should be doing and not something we need to be encouraging. As we move up the ladder, we move into doing for people. So we're engaging and involving people, we're consulting them, we're informing them in a meaningful way about what might be happening in research development or service development. And I would argue this is the bare minimum that we need to be doing with patients and the public when we're developing research and new services. And then at the very top of the ladder is co-production, co-design, and I'll talk about this later, but also co-creation is another similar word in the mix there. And this is where we're doing with people. So the gold standard of this is that we're working with patients and the public in an equal and reciprocal partnership. So we're not telling them what's best for them. We're really hearing their voice when they're saying what they need out of new healthcare services and new healthcare treatments. And we're working with them to develop the best solutions in those particular settings. So in terms of the methods, if we're looking at engaging and consulting with the public, we might have some focus groups or questionnaires or surveys, or we'll invite people to seminars where we can inform people on progress of things that's happening. So those are some methods that we can use there. If we want to move up that ladder of participation, we can start to look at co-production, co-design and co-creation. And essentially, this is a move from traditional methods where you have patients and the public and researchers and designers of services all in separate boxes doing their own little bits and pieces, to getting everyone in the same space and sort of creating together, designing together and coming up with ideas for research together, ideas for services together, testing those things together. So it's metaphorically getting everyone in the same space. Sometimes it can still happen asynchronously, but the philosophy behind it is working together with people. The co-part is really important there. And some examples of how we do this. So you can do things like, focus groups and interviews with people to get them co-designing and co-creating with you. But in particular, when I'm looking at sort of bigger research projects and bigger intervention developments, we can use creative methods to try and break down large concepts for people and to get people really engaged and thinking creatively about innovative solutions to various health and social care challenges. So this slide here are some examples from some projects I've been working on. The one on the left is where we got people to create a technology service to support older and people with disabilities to live at home independently for longer and to provide their family with reassurance that they were okay to live alone. So we used collage to get people to help us to design and build what that service would look like. In the middle there, we've got Lego. So this wasn't my project. This was a participant in a training course we had on co-creation. And they used the skills they learned in the training course to use Lego Serious Play, which is a methodology to get people creatively thinking. And they used that method with their cohort of people with learning disabilities to talk about some changes that were coming up in their housing provision and to get them to feedback in a meaningful way and have conversations around what that would look like for them and the changes that they would like to see implemented. And then on the right, we've got a project where we were tasked with co-creating a new piece of software to improve the identification of deteriorating patients earlier than might normally be expected. And we held a series of co-creative workshops followed by some sort of, my brain's gone dead and I can't think of the word. We got people to actually use the prototype software in a mocked up environment. So I guess role playing is something we used to get them to use the software and see how it would work in a role play environment before sort of testing it out in a real patient environment. If you want more guidance on sort of how you can do PPI and a framework for doing that, there's quite a few, and I don't have time to talk to you all about them today. For the case study, I'm going to talk to you about using a co-creation framework, but for those of you who are interested in the variety of frameworks that you can use and to kind of guide you through how one might approach PPIE in a research project, this paper here is a good overview. It's a systematic review of different frameworks that people have used. So this is in the references at the end of this presentation, and Lauren, I'm happy for you to share the slides with people afterwards if they want access to the references. So that's a good paper to kind of as a starting jumping off point if people want to explore the frameworks that are available. So although PPI is not our research, it might not always need ethical approval. So if you're doing research in a university setting or an NHS setting, for example, or a social care setting, often you're going to need ethical approval for that. And PPI is not strictly research. So quite often we can do our PPI, we can get our feedback on our research without getting ethical approval. However, there are sometimes exceptions. Particularly if you're working in a co-creation framework, sometimes the lines between the PPI and the actual research itself can become a bit blurred. You might also want to publish the results of your PPI, in which case you would need to prove that you had ethical approval for that if you were to publish in a journal, for example. And you might also, just as best practice, want to get some ethical approval, particularly if you're working with sensitive subject areas or a vulnerable population. So I would just say seek advice from the organisation you're working within. Sometimes you don't need it, but sometimes you might want to get ethical approval as if it was part and parcel of your research, if that makes sense. But even if you don't get ethical approval, that doesn't mean you shouldn't apply ethical best practices to your PPI work, particularly if you're working in sensitive subject areas. You know, people might get upset talking about particular subjects, so that's something to be mindful from. How are you going to protect people, look after them if they do become upset or if something goes wrong? Still think about informed consent. Let people know what taking part in a PPI activity means, what it means for them. You know, what do they need to contribute and what are they going to get back in return, so they can make a really fully informed consent decision to take part in your PPI. Think about, I mentioned before, inclusivity and diversity. It's not ethical best practice to completely ignore, you know, key populations who are going to be affected by this research. You know, bring as many people in as you can and think about who is going to be affected by this research or who might be affected by not being included in the research. Accessibility, think about where you're holding your PPI activities. You know, if it's a focus group or a workshop, are, you know, people with disabilities able to, you know, get into the actual workshop itself? If it's held online, does that work for people? Do they have internet access? You know, think about neurodiversity, you know, the different ways that people might want to participate in PPI activities. Data protection, you might still be collecting data from people, for example, personal details, to get in contact with them. They might give away some personal details as you're speaking to them, so think about how you're going to deal with that data. Reimbursing people. People will give their time up for your research project, and NIHR have some guidance on remuneration for people and what are appropriate amounts for various different activities. You know, sometimes people can give up significant amounts of time to take part in PPI, and they're giving up their time and they're giving you their expertise. So that's something you kind of need to think about. And also acknowledgements. you're going to get some really good insights from people potentially in your research that can make or break it. And most of the time it's going to make your research, and you're really going to benefit from that. How are you going to acknowledge the people who kind of put those ideas into your research? So I ask for sort of my projects, you know, do you want to be acknowledged? How do you want to be acknowledged? You know, you can include their names, you know, within authorship on papers if that's appropriate, in the acknowledgement section on papers, and in things like presentations and such. So that's something to think about. As you're doing, and once you're doing your PPI, you might also want to think about, is this working? Is this having an impact on my research? And actually some funders will ask you to report the impact that your activities have had on your research. But even if you're not required to do it, it is good practice to evaluate and report on the impact that your activities have had, even if it's for your sort of own knowledge and learning and improving things project on project. And there's a number of tools available for this, and there's two that are recommended by NIHR, the Public Involvement Impact Assessment Framework, and for reporting the GRIP2 checklist. And these are also good to look at before you start your PPI journey. So rather at the end when you have to report and evaluate, it's a good idea to look at these tools at the beginning of your PPI, because it can give you some ideas on where to include people and how to include people, and give you a bit of an overview. They can almost be used as a framework actually for when you're thinking about the kinds of activities you're doing. So let's move on to a case study where I've used PPI. So this was the PULSE project. PULSE stands for Postural Tachycardia Syndrome Exercise. And the aim of this project was to develop an active living intervention designed by people with POTS for people with POTS. So POTS is Postural Tachycardia Syndrome, and it can really affect well-being and quality of life due to its many symptoms. The condition mostly affects, but not only, women aged 13 to 50, and the symptoms include abnormal heart rate rises when standing, palpitations, dizziness, fainting, and long-lasting and sometimes quite severe fatigue. Attending education, earning a living, and caring for people can all be severely affected by these symptoms, and the impact on the healthcare system can be quite significant. At the moment, medical treatment isn't always effective for POTS, but there is evidence to suggest that active living interventions like increasing exercise and activity may be helpful for some people. So our aim was to create a feasibility trial protocol and a rehabilitation intervention for this patient group. So we used a co-creation framework that was developed here at Coventry University by my colleagues Gemma Pearce and Paul McGee, and it's called the 3 Co's framework. And essentially there's 3 broad phases where we co-define with people. So we define the problem with people, we design the solutions with people, and then we refine those solutions with people. So we used this as our framework, and we had 18 PPI members attend our co-defined session, which was a teleconference in the end due to bad weather. So in terms of accessibility, we had huge snow at the time, so just physically we weren't able to be in one physical space together, so we had a teleconference. We were also going to have a face-to-face and teleconference option before the snow, because, as I said, a lot of people with POTS have issues with fatigue, so coming physically to a location in Coventry might not have been possible for everyone. But in the end, it was teleconference for everyone just due to weather. And then we had 16 co-creators with a mix of expertise who attended our subsequent co-design and co-refine sessions, which was a mixture of workshops and meetings. So just to show you sort of where we used the different methodologies as we engage people throughout the study, from idea generation to seeking and applying for funding, we got feedback from teleconference and emails. And then once we got into designing the trial and the intervention itself, so that's when we were thinking about recruiting participants, conducting the research, and how we were going to analyse and interpret the results. We did some co-creation workshops with some further email feedback on the results as they came in. So what did we find from our co-defined teleconferences? So we found that with this patient group and their carers, we also had their carers in the teleconference, the research topic was a really important area of study for them. Being able to do exercising and increasing their activity levels was really important to this patient group. They said that there were concerns about language use, so they said that we should avoid the word exercise, as this could suggest really vigorous levels of activity, which would be off-putting for this patient group. And they felt that the focus should be on movement-based activities with very slow progression, and the course should be tailored for people's needs. It shouldn't be a one-size-fits-all solution. Pacing and other psychological techniques were important to ensure that any increase in physical activity is manageable within a person's daily routine and their physical capabilities. And we found that practitioners, it was important for them to receive specialist training to enable them to really support this patient group, who often have comorbidities such as Ehlers-Danlos syndrome, chronic fatigue syndrome and ME. And in some of those cases, inappropriate support can exacerbate symptoms. So that further highlighted the need for this tailored approach with clinicians who had specialist training. And people said that the preferred delivery of the trial of this intervention should be a mixture of group and one-to-one sessions supervised by healthcare professionals who would listen to people living with POTS and understand the particular everyday challenges that that patient group faces. So we kind of took that feedback on board, and we took it to some co-design sessions, which is where we had a wider stakeholder group, as well as people living with POTS. We also had clinical exercise physiologists, researchers, health psychologists, so those people that the patients and carers said needed to have an input in the design of this trial. We had nurses, charity representatives, people delivering POTS services, physios, patient services coordinators, designers and project managers. So as I said, we kind of thought about the sort of wider care pathway and those people who could have a say in whether this intervention would be successful or not in the real world. So during these workshops, we explored the concerns raised in the co-defined session, so worries about the intervention, the level of physical activity required, the use of language, how do we recruit people to our trial, what does the intervention look like, and how do we measure if it's successful or not, what outcome measures are appropriate to use, what would the patients consider a successful trial? Do we need to be looking at just physiological measures, or do we need to be looking at psychological measures such as quality of life as well? So we kind of took that away and sort of drafted up what we thought the intervention would look like. And then we had 3 rounds of co-refining to say to people, this is what we think the intervention in the trial looks like. Are we close? What needs to be adjusted? What needs to be changed? So we had an online workshop to gather feedback on the draft that we had co-designed. And then we also had to have another online workshop. During this time, we moved into the COVID era. So then we initially had an intervention that had some face-to-face elements, but suddenly that became illegal and inappropriate. So we had to quickly further refine the intervention again to move it fully online. And based on feedback, we co-designed and co-refined a manual for staff with staff training to really make sure that they understood the sort of the psychological background to getting people into increasing their activity levels and dealing with that sort of tailored support for people based upon their abilities. So how did involving people in these teleconferences and co-creation workshops impact on our project? Well, we, in a relatively short amount of time, we got to a designed trial and intervention. So this is quite quickly what it looks like. So we had an intervention group and a control group. The control group was best practice usual care with no supervised rehabilitation. And then the intervention group itself, we had people there was an individual assessment to get their baseline and familiarisation with the lifestyle exercises they would be asked to do. And then there was a supervised outpatient exercise program that they did at home with some recumbent bikes, which we provided to them because they couldn't go in person to use any gym facilities anymore. And we provided these lying down bikes for people to use in their own home, so they could still do the exercises despite us being in sort of relative lockdown at the time. There was an element of psychosocial and motivational support and educational, and then that lifestyle-based physical activity. So this diagram here was really designed with people with POTS and their carers and other relevant stakeholders. So that was our first impact. We just got something designed that we were hopeful that would work. And we've now sort of ran the trial. It was successful. I'm not very au fait with the quantitative statistics because I'm a sort of qualitative researcher, but we did get some initial feedback that there is some sort of positive effect on people's symptoms. But because I was involved in speaking to people through some telephone interviews on how the trial worked and the experiences of being in the trial. And here are some quotes from our participants. So first of all, we had people who their symptoms improved. There's one quote here: "I've got loads better. The last time you called me and I said I was still having POTS, I just done my active stand test and I've improved so much on it." And so active stand test is one of the baseline measures we had for people, and it can be quite uncomfortable for people with POTS because of their increased heart rate when standing. So this person, I can't remember what their baseline figure was, but they moved to being able to do it for 10 minutes. Some people can't bear it for sort of more than a few seconds or 1 minute. And I don't feel hideous when I do it. So that person had a real improvement in one of their baseline measures. One person said, "I can't reiterate how good it's been and how much it's changed my life, to be honest, so I'm just really thankful." So that's another person who really benefited from taking part in the trial. And we feel that because we involved patients from the beginning through the trial to the end, it wouldn't have been successful if we hadn't had that input, if we hadn't tailored the trial to this patient group, if we hadn't had their say in where we need to recruit participants from, what the trial looks like, what the exercises look like, what kind of psychological and psychosocial support people get. And then the bottom quote is actually something from one of the dropouts of the trial. So we interviewed the dropouts to sort of ask them, is there anything we could have done to make the trial easier to take part in? And this person said, "I'm not sure, to be honest. I think honestly it's just the time in my life right now. I'm just too busy and I can't afford the energy to do it. I don't think it's on you guys, to be honest." And we actually got from our feedback very little changes that needed to be made to the trial. And I think that's because we involved people at the beginning. So we really saved ourselves some time and resources there by involving people from the beginning. We made something that was appropriate for that patient group in the first place, rather than developing it without their input and then finding out that we got all sorts of things wrong. So I think that quote there is a testament to how involving people from the beginning can really sort of make your research more successful. And it might seem like a lot of time and resource at the beginning, but it saves you time and resource later on if you get those voices included at the right stages. So in summary, PPIE is important to ensure that the research we conduct and thus any resulting interventions or services that are developed from that research are relevant and acceptable to the public and patients, the very people it's supposed to help. It's really important to engage people at all stages of the research cycle, from idea generation through to dissemination. And if you really sort of want to fully embrace the philosophy, we really need to be taking the ideas from patients and the public themselves and getting that sort of bottom-up approach to research rather than imposing our ideas on people. Make sure that you're engaging with the right patients and you're considering diversity and representation, and you're not ignoring people's voices. You could end up with something that at best doesn't fully address people's needs, but at worst you could harm people from not including the right voices. Consider which methods are most appropriate depending on the sort of where you are in the ladder of participation and what kind of feedback you need from people. And finally, ethical approval isn't always necessary, but still consider best practice and ethical principles when you're running your PPI. So that's everything. I have got references. Like I said, I'm happy for Lauren and the team to share these slides with people afterwards. I'll stop sharing now. I don't know if we've got any questions.
Thanks, Nikki. That was excellent. Lots of useful tips and very insightful. Haven't spotted any questions in the chat, so please feel free to leave your questions or pop your hand up and we can unmute you if you want to ask a question.
If anyone has any questions afterwards, just drop me an email and I'm happy to answer them.
While we're waiting, Nikki, then can I ask how you recruited your public contributors for your POTS project?
Yes, so I think we were really lucky in that one of the research team had POTS. So we had a patient researcher on our research team. So she had some great contacts already. So that's something that I would advise, if you can get someone with that actual lived experience on your research team from day one, that really, really helped us. But yeah, if you don't have that, I think sort of getting into charities that represent that patient group can be really helpful. So our patient researcher had contacts with various charities that were helpful. And we also had clinicians in the area who were able to sort of recruit through their patient contacts. But yeah, I think it's having that person with the lived experience. They usually have networks and connections, and you can start a snowball to build your PPI group. And like I said, once you've got a few members, you can ask them if they know people, and you can sometimes grow it relatively quickly. It's harder for some patient groups, particularly with rarer diseases, but yeah.
Yeah, but the networks is important, yeah.
Yeah.
We've had two questions. So one is, did you use the PPI team as part of the main study? So I'm guessing that's, did you use the public contributors?
Yeah, so we made the decision not to, and just because they've been so involved in the development, they were, I guess, a bit biased towards the results of the research. They had as much input as us in terms of how it was designed. So we were concerned that that might bias the research. So one of our exclusion criteria for the research was if you had been involved in the PPI, you couldn't be involved in the trial. And we were upfront about this when we were recruiting the PPI group, because if they wanted a chance to be in the trial, we didn't want to take that away from them. So again, in terms of informed consent, we let people know if you're a PPI member, you can't be in the trial.
Makes sense. A good question.
Yeah.
And then a question, how many community researchers did you have in the team?
So we had one patient researcher who was a core part of the research team. And then I think we had the people changed because of changing sort of levels of health and being able to contribute. I think we had about 2 PPI members who would attend our research management group catch up. So they would every sort of quarter, and they would meet with us to hear how the research was going and talk about any problems we were having, for example, with recruitment and things like that. And then the wider PPI group, we had 18 people in the initial PPI group. And then in the workshops, because it was a mix of different stakeholders, I think they were, off the top of my head, about 5 or 6 patients in those groups.
Wonderful, thank you. Any other final questions? Just some thank yous, Nikki.
Okay, thank you very much. Thank you everyone for attending and listening. Yeah,
Harmony's popped your email in the chat as well. Oh, we've got one more question.
That's great, thank you very much.
Did you also have a PAG as well as the researcher group?
What do you mean by PAG?
Hiya, it's me, Sasha. A public advisory group. So I'm from Leicestershire HDRC, and we have created a PAG now. We've recruited and we've got some onboarding. And from the PAG, we're going to use that group to kind of help us create our community research group. So we're going to use their intelligence to then source another group, which is going to form our community research group. I just wanted to know, did you just go straight for the community research, or have you done it in steps like we have, or?
So for this project, we just went straight for the community research, but yeah, we did have some key members who we didn't give them that title, but that they were sort of key members in all of our meetings. Yeah.
Okay, thank you.
Okay, fantastic. I think that seems to be the end of the questions then, so we'll leave it there. Thanks again to Nikki for presenting today. If you want to see what other upcoming webinars we have, then look on our website. We've got one next Wednesday on an introduction to research methods. So yeah, please get in touch with us at the HDRC if you have any other questions, and thanks for coming.
Lovely. Thank you. Thanks a lot. Bye.
Thanks, Nikki. Bye.